Egyptian Society of Radiology and Nuclear Medicine. وهتبتدي معانا دكتورة رحاب الشيخ. She's a staff member of Applied Health Science Technology College في ماست University. دكتورة رحاب هتكلمنا النهاردة عن practice standards for positioning patients during breast imaging. Please, Dr. Rehab, the floor is yours.
بسم الله الرحمن الرحيم. أنا دكتورة رحاب الشيخ, lecturer in Radiodiagnosis, Mast University, and the breast imaging consultant. Today, our topic will be what are the practice standards for positioning patients during breast imaging. The modern mammography came into existence since a very long time ago. Different breast imaging modalities advanced through the years to become realized by too many modalities. The gold standard technique is the mammogram, the tomosynthesis, and the recent contrast enhanced mammogram, the 2D handheld ultrasounds that have been recently developed into the 3D ABIS, automated breast ultrasound, the MRI dedicated breast coils, and the recently introduced into Egypt the positron emission mammogram and the molecular imaging. While the standard imaging modality will always remain the mammogram. The basic mammographic views for an average-sized breast are the standard for images 2 mediolateral and the 2 CC views, while if the breast is larger, we can add the additional views. Before imaging, please, on inspection, you should document any scar, any dermal mole, skin tag, accessory nipple. If the patient has any congenital nipple retraction, or if she is a lactating lady, we should document these infos. How to perform the mediolateral oblique position? First, the C-arm of the unit is rotated about 45 to 60 degrees angle so that the cassette becomes parallel to the pectoralis major muscle, and the film holder should be kept high in the axillary fossa. The arm should be abducted at the elbow. Then have the breast up and out position so that the nipple becomes perpendicular to the chest wall. Open the inframammary fold angle and maintain adequate compression. Concerning the training order view, it should include maximum amount of breast tissue in an axial plane, with visualization of the complete amount of the medial breast tissue or the cleavage, and this might be helped if you raise the contralateral side. With visualization of a part of the pectoralis major on approximately 30% of all your CCs. The goal for mammography positioning should be to bring the breast back to its normal position, thus besides the nipple become perpendicular to the chest wall on all screening views, so that to maximize the visualization of the whole mammary gland and to avoid any superimposition. This goal can be attained if we understand well what is the parameter of the breast and the pectoral muscle anatomy and the importance of the pectoral nipple line. We should include the whole parameter of the mammary gland under the compression plate. Laterally is the mid-axillary line, medial is the mid-sternal line, inferior is the inframammary fold, and from above and superior include major part of the pectoralis muscle, shallow, and always keep the unit arm angle parallel to the fiber of this muscle. Always keep the nipple perpendicular to the chest wall in your views. I will give you some tips to be used during examination. Please keep your happy face in front of the patient as at this moment she might be somehow stressed. Then elevate the breast so that the nipple becomes perpendicular to the chest wall, whatever the degree of sagging in different women breast and breast build, and keep always the pectoral nipple line at 90-degree angle with the pectoralis major and in the CC views. Another tip, if you and stand on the medial side of the breast to be imaged. Adjust the height of the film receptor to elevate the inframammary fold. Pull the breast with both hands. Lift the contralateral side of the breast so that to introduce the medial aspect of the breast into your field of vision. Guide the patient head forward and around. Relax her shoulder and down and back and pull on the lateral breast tissue. Sometimes you might need some additional view to examine specific regions of the breast. The 3D tomosynthesis digital mammogram is mainly used for screening in patients with a dense breast, using the same standard position as in a standard mammogram examination, with the tube moves in an arc across the breast, resulting in reconstructed 3D images viewed every 1 millimeter. The contrast-enhanced mammogram. Please, before any contrast injection, we should check the creatinine level. Any patient with known iodine contrast allergy should be excluded from this study. We then place an intravenous catheter in the forearm, and the injection of 1.5 milliliter per kilogram body weight of any non-ionic contrast agent using a power injector or manual forced bolus will be injected. The whole idea of this examination technique depends on the fact that the malignant cells absorb any contrast very early with early washout. So we started the injection, then wait 2 minutes. Then we started the standard positioning for any mammogram, starting with the CC views, starting with the normal side, then the suspected pathological side, then turn your C-arm to perform the mediolateral oblique of both sides, starting with the pathological side, then terminate with the normal mediolateral oblique side. With contrast mammogram, it delivers intermittent exposures of low energy and high energy acquisitions at 1 to 2 seconds interval during the same session of compression. That's to say, the whole CCs will be terminated at the minute 2 and 3, and the whole mediolateral will be terminated at up to the 6 minutes. So the examination is rapid, and then all the non-enhanced anatomical structures on the low energy and the high energy acquisition will be eliminated by the computer, and the images with the recombined will be recombined to yield the recombined subtracted mammogram images with the hyperdensity indicating the iodine uptake. For reading, we use the low energy mammogram image and the recombined subtracted mammogram images. Here are some tips for you. Don't forget always to keep your lovely smile all the time through the examination to keep the patient relaxed. All patients were requested to hold their breath during the exposure to avoid motion artifact, and don't remove the cannula until 15 minutes later. Sometimes the radiologist may request delay film for any delayed enhancing lesion, and always ask for previous film for comparative studies. Recently introduced in Egypt is the automated
Sure, checking. Next speaker, Dr. Mr. Let's